talk about RFA for metastatic thyroid cancer of a lymph node. And I'm really excited to hear what you have to say about it because this is something I'm still learning about. Most of my experience has to do with benign nodules, and just now we're starting to see more patients with thyroid cancer pursuing RFA. But this is another little layer of the onion as we kind of pull back and learn about all the different applications of RFA. So if you could start off by just kind of giving me a little intro to what exactly we're talking about here with RFA for metastatic lymph nodes.
So let's start a little bit talking about a thyroid cancer and then metastatic disease to lymph node. So when we take a patient with thyroid cancer, data show after initial surgery, around 5 to 30% of those patients will have a recurrence of thyroid cancer based on the initial surgical pathology report and what we call risk of recurrence. And most of the time, 90 to 95% of the time when that recurrence happens, it happens in lymph node in the neck. When the cancer recurs after the initial surgery and it involves lymph node in the neck, and we're talking about considering treatment with RFA, the question comes like, why RFA? Why we can't do more surgery? It is the first step is to consider surgical intervention on recurrence and what we call a virgin neck, which means a neck that did not have surgery before in the area where the recurrence is happening. But the problem comes when we're talking about repeating surgery in those areas of the neck where a surgery already been done. The data show there's a higher risk of complication, higher risk of damage to organs in that area, nerve damage, a vascular, a component being affected, a recurrent laryngeal nerve damage in the central component, increased risk of hypoparathyroidism and hypocalcemia when we do treatment in the central neck compartment. And that's even with an excellent surgeon. And that's not to say our surgeons are not great. They are great, but it is really difficult to manage this area when you have a lot of scarring and fibrotic tissue that cause it to become solid like rock, and you're trying to dissect that area to get the tumor out. It becomes a little bit tricky. And this is where RFA come in, or other ablation technique, and mainly we're talking about RFA because that's what we do, but this is where they come to help us reduce the risk of complication and achieve the goal of curing this patient, hopefully, or controlling their disease with a treatment with RFA.
That's really exciting. I think any patient who's been through surgery is going to be not excited about the prospect of further surgeries. I think if I were in that position, I think it would be a relief to hear that this is a possible option.
Yeah, it is a possible option. And I think it will change the way we approach thyroid cancer in many aspects, those ablation techniques. But I will caution that not every patient will qualify for maybe this type of treatment. And we need to be cautious about that long-term data is not there. We don't have long-term data about morbidity and mortality for patients with thyroid cancer with treatment with those techniques. But time will give us the best answer. With time, we will know this is the right treatment or not, this is the right approach or not.
What patients actually can pursue RFA for metastatic thyroid cancer? Could you tell me a little bit about what the indications are for that?
Absolutely. So as you very well understand, papillary thyroid cancer is a very common cancer in women. And according to some estimates, it's already the 4th most common cancer in women right now in the USA. And majority of cancers in the thyroid are papillary cancers, which are very treatable, and mortality rate is very low, between 1% and 3% for majority of low and intermediate risk cancers. However, recurrence is very common. Unlike other cancers, recurrence is extremely common, even though mortality rates are very good in thyroid cancer. And so we have to have a plan to manage these recurrences, and most of the recurrences are in the neck in the form of lymph node metastasis. And if you actually look at historical data for most cancers, if you remove enough lymph nodes, between 40 to 60% of all patients with papillary thyroid cancer have some level of lymph node involvement. However, majority of these lymph nodes do not have any significant impact on long-term outcomes, but some of them can be close to anatomically sensitive structures. And after a few surgeries going in after these lymph nodes, you realize that eradicating the disease with repeat surgery comes with a cost of side effects, patient pain, discomfort, and recovery associated with reoperating on a field that's already been operated on before, and there's scar tissue and distortion of normal tissue. This is where RFA comes in as a useful adjunct. We started doing these procedures about 3 years ago when we were asked by our local tumor board to help a patient who was no longer a surgical candidate because she already had a couple of surgeries and she had a vocal cord paralysis on that side, and surgeon was not comfortable going into that area. And we performed that procedure and it was a big success. We already were aware of international data looking at how good it is for lymph nodes. And basically what the data from China and Korea shows is that between 70 to 90% of lymph nodes treated with RFA will completely disappear and not come back. However, this is not a replacement for regular surgery where multiple lymph nodes are involved. This is perfect for somebody with low or small volume recurrence who's already had surgery and repeat surgery and does not want more surgery, and there's only 2 or 3 lymph nodes involved. It seems a bit of an overkill to go after 2 or 3 lymph nodes with repeat surgery when patient has already had some scar tissue in the area and is at risk of surgical morbidity and complications. In these situations, RFA becomes a good option because if you look at the success rate, majority of these lymph nodes totally disappear with one session of treatment and don't ever recur majority of the times. So we looked at that data and we decided that for the appropriate patients, this is something we were going to offer them. And for the last 3 to 4 years, we've been doing it quite regularly, which is one of the publications that we are talking about today, which is an instructional video almost of a real case that we did to show other specialists in the country to learn how to do RFA for lymph nodes in the lateral compartment, which is a little to the side. And it also is fraught with its own complications because there are certain nerves and other vital structures in the lateral part of the neck that have to be catered for or have to be deemed sensitive. So you have to be careful around those. We've done close to 20 of these lymph nodes so far, and a full paper we've just about ready to submit for publication, but our results are in line with what we saw in China and Korea. We get very good results with one session, and so far, after only 6 months of follow-up, up to 50 to 60% of lymph nodes that we treated that are metastatic to completely disappear. The others are more than 90% smaller. The thyroglobulin level, which is an indirect marker of disease activity and disease presence, has declined in line with the papers we saw from China or Korea. So it's an exciting adjunct to surgery for patients who are no longer surgical candidates or who don't prefer to get more surgery for their own reasons.
If a patient has undergone RFA for a primary cancer and has a recurrence, would they be a candidate for this as well? Or would they need to undergo surgery at that point?
If it is already metastatic to the lymph node and you already had RFA, at this point in time, the current standard of care would be to consider surgery. Remember, metastatic disease that is already metastatic to lymph nodes and primary cancer is not a good situation where you want to use RFA. RFA for primary cancer is right now recommended for micro disease, which is less than a centimeter, that is not metastatic, that is completely intrathyroidal. These are the types of cancers previously all we did was to observe them based on the current guidelines. But now, since we understand that patient anxiety is very high when you offer them observation, for the right patient, this is an option to manage primary cancer. But if it is metastatic, then this is not an appropriate option.
Well, tell me about your experience with doing this on your patients.
So we have quite a few patients with thyroid cancer we have treated with a lymph node involvement. That include what we call central neck compartment and lateral neck compartment. Those patients who we evaluated who had history of cancer and had an evidence of recurrence and lymph nodes in the neck. Generally, we consider that for patients who have a limited lymph node involvement. If we're talking about a patient who have multiple lymph node involved, we're talking about a patient who had bilateral neck involvement, then we're talking maybe surgical intervention is a better choice, especially in a patient who did not have a surgery on the lateral neck for the thyroid cancer. But if the disease is limited, involving 1 to 2 lymph nodes, they're small in size, we can confirm on biopsy they are cancer, then we are feeling comfortable to treat those patients. and hopefully our recent data will be shared with everyone. It will show that we had a good success rate, which does match the international data. We got closer to 50% of our patients have complete a resolve and tumor disappearing and lymph node disappearing after treatment with RFA. And a good number of patients had a significant volume reduction ranging between 70 to up to 98% volume reduction, which also match international data with volume reduction. Some of the studies internationally published in RFA showed more volume reduction, but our data match the studies published in South Korea, which we are excited about.
The difference is that we don't have the long-term follow-up in the US yet. So majority of the lymph node disappearance typically happened at 1 year or 2 years. But short-term follow-up at 6 months, 6 to 8 months is pretty similar to what we saw from Korea and China. So we've done a total of 20 lymph nodes, and we're doing some more next month. And the reason we continue to do this is because it's a very common occurrence to have metastatic lymph nodes. And if there's only 1 or 2 or 3 lymph nodes and you've had a couple of surgeries and you don't want more surgery, or the surgeon thinks that the surgery is fraught with possibility of complications, it is worthwhile to consider this technique. Obviously, operator experience and expertise comes into it because lymph nodes are very small. It is really hard to isolate them from vital adjoining critical structures. Hydrodissection, which is a technique that we use to separate lymph nodes away from critical structures, is very important to master. Since we've been doing this for almost 4.5 years, we know how to do all these things, but it is a little challenging, but it is very rewarding because the results are extremely good so far.
And were there any major differences between your data and the overseas data?
Not major difference from our complication rate. For us, we didn't have any major complication, but our sample is small. When we look at international data from complication rate, we do see that a patient who have lateral lymph node involvement, the risk of complication is really low. It's estimated to be around a 2% to 1%, and the average complication rate for ablation technique is around 5%. But when we look at central neck compartment, complication rate jump up to 16%. We didn't have a lot of patients. I think we had few who had a central neck compartment involvement, and most of our patients had lateral neck. So it's possible the sample was too small to detect a problem, but we're lucky, and I think hopefully we have the skills to do this procedure without causing more harm to our patient.
I watched your video of the treatment of a metastatic lymph node, and I noticed that you mentioned that you did a fixed technique and not a moving shot technique. Could you talk on that just for a moment?
We use the moving shot technique in benign nodules. So if you were to envision a large nodule this big, the different areas will be moved along and ablated. When you think of a lymph node compared to a benign nodule, it's about this small, and you don't have to move it around to ablate different parts. You just have to isolate it away from other vital critical structures and get into the center of it, and then ablate, and then move a little bit if you need to just ablate the different areas. Moving shot technique basically alludes to an antenna being inside a benign nodule and then moving while you're ablating, so you can ablate most of the area. In a lymph node, which is very small, only a small area will be ablated, and you cannot move it around while you're ablating. So that's the difference between a benign nodule and a lymph node.
Generally, when we think about the active tip of the antenna, it's a small percentage of the whole antenna. So we're talking about the antenna may be as 7 centimeter in length to up to 12 centimeter in length, but the active tip is maybe 7 millimeters, which is not even 1 centimeter. So not the whole antenna deliver energy, it's just that small part of the antenna. When we're dealing with a nodule that measures 3 centimeter, 4 centimeter, that 7 millimeter will treat a small part of that nodule. So the moving shot technique helps target multiple areas in that nodule, and at the same time, by moving, it reduces the risk of damaging other organs in the neck by not staying in the same spot. When we're talking about lymph node involvement, as we usually preserve this for lymph node less than 2 centimeter. So we're talking about 2 centimeter in the largest diameter. So those lymph node could be 7 millimeter in the short diameter. So when you're sticking in an active tip that is 7 millimeter, that whole active tip is covering the whole lymph node. So if you move, you're basically treating the surrounding tissue. You're not treating that lymph node itself. So this is where we use a fixed technique. We stick the needle inside the lymph node. We treat part of that lymph node, and then we change the position and we treat a different part of that lymph node. Because we're trying to treat only the lymph node. We don't want to target the surrounding tissue, damaging organs that are not involved with the cancer.
So you talked about complications being very low. What are the risks of having this procedure?
So this is where we worry mainly in the central neck compartment. The central neck compartment, after removal of the thyroid gland, the tissue collapses on itself. So the carotid artery, the trachea, the esophagus, they get close together and they are separated with a small amount of soft tissue. If a lymph node is sitting in what we call the tracheoesophageal groove, which is basically a space between the esophagus and the trachea, that is going to be in close proximity to what we call the recurrent laryngeal nerve. That nerve is responsible about voice. So if that gets damaged, we may end up having more problem with voice, alteration of voice, or paralysis of nerve. So we do use mitigation technique like hydrodissection. We inject fluid around the lymph node to make sure we have a large cushion of the fluid to reduce the heat effect on any surrounding organs in the neck. So this usually helps. So we worry about that in the central neck. We worry about puncturing major organ in the central neck. So someone who has the skill and technique, making sure the placement of the tip of the antenna in the right spot is important so we don't cause damage to the esophagus. All of that are very important when we're talking about treatment in the central compartment. Now, when we think about the lateral neck, those lymph nodes generally sit around the carotid artery and the jugular vein. We have a major nerve in that area, which is the vagus nerve. So we need to know exactly where the vagus nerve, make sure we do our hydrodissection, we protect that nerve. We may need to repeat hydrodissection more than once during the procedure to make sure we protect that nerve. And then we are applying our treatment intentionally and carefully into the right spots that we need to treat to achieve the goal with lowering complication. Now there's other areas in the neck that can get involved, or lateral, and that can cause more damage to other nerves that are responsible for the shoulder, which can cause shoulder pain or shoulder weakness. Generally, we don't see those as common, as most of our recurrences really localized around the jugular vein and the carotid artery.
The risks are pretty similar to what you would get in terms of RFA of a benign nodule. If you're close to a vital structure such as the nerve which supplies the vocal cord, that's one of the more common areas of recurrence in the central neck, very close to the nerve that supplies our vocal cords. In surgery and reoperative surgery, the risk is a little higher. It can range anywhere between 3 to 9%. With RFA, according to the studies from abroad, it's a little lower, between 1 and 3%. So far of the cases we have done, because of successful hydrodissection, where we inject cold water as a buffer between the lymph node that is cancerous and other vital structures, we've had 0 such complications. But again, we're talking about percentages in the hundreds of cases, and we've only done close to around 20. Other complications that can occur are obviously bleeding, infection, and those types of things that happen with any percutaneous procedure. Again, those are very rare, and we've not had any complications like that.
Do you think that there's more metastatic disease in the US because of the different healthcare systems and the way that we biopsy larger nodules, as opposed to over in Korea, they biopsy very, very small nodules? Have you seen any of that?
In Korea, they used to do a lot of that, and they've started to move away from all of that. In the US, we have a larger incidence of cancer among certain population in certain states. For example, the state I live in Utah, had close to 100 above ground nuclear tests, if I'm not wrong, in the Nevada desert in the 50s and 60s. And there was a phenomenon called the downwinder phenomena, because the wind blew in this direction and it became very common. So if I'm not wrong, we're in the top 3 states out of all the states in the US in terms of the highest incidence of thyroid cancer. So there are other environmental factors that we're exposed to compared to other countries, which might be playing a role. But that's just something that we're getting to know more and more about.
You talked about this a little bit at the beginning, but who is a really good candidate for this technique?
So a good candidate for radiofrequency ablation at this time for treatment of metastatic disease to lymph node is a patient who had a surgery on the thyroid gland, who had an evidence of recurrence, who had already a surgery on the lateral neck, which is the standard care, and who is in a high risk of having complication for repeat surgery. If the surgeon feels that the surgical intervention is still a reasonable choice with a low risk complication, surgery is still the standard of care for treatment of cancer. If lymph nodes are extremely large, we're talking about 3 centimeter, 2.5 centimeter, large lymph node, we do know radiofrequency ablation may not be able to completely ablate those lymph nodes, and surgery will be preferred for those patients. But it's really can change based on different circumstances. What I mean by that, as a patient who have a cancer that is advanced and surgery may be with a high risk, and now we're considering this surgery as a palliative, this may be a candidate for treatment with RFA when surgery is not a choice. Well, if we do know that surgery will lead to cure and does have a low complication rate, then surgery will be the choice. Now, another thing that will be important for us to evaluate is those limited number of lymph nodes or multiple lymph nodes. If we have multiple lymph nodes in the neck, then treatment with RFA may not be the best choice because we do have multiple areas of the neck is involved, and that may not be able to treat all of those areas in a timely manner, which means that we may treat some is still in the neck. It may take time before we repeat another treatment, so it may not cover all the areas that we need to treat for those patients. But for patients who have 1 or 2 lymph node involvement, who are considered a candidate for active surveillance, who are considered that they have low risk of progression of disease, then maybe thinking about treatment with radiofrequency ablation to eliminate that disease and reduce the anxiety that comes from knowing that there is a cancer in my neck and I'm just watching it, it may be a good choice, especially if this treatment comes with a low risk complication. Again, I would caution here that long-term data is not there to support the morbidity and mortality rate associated with this type of treatment, but it's an open question that hopefully more data, more research will be able to answer. Another point I would like to share here with, think about lymph node. When we have recurrence of thyroid cancer at lymph node and we monitor those patients, majority of those patients have lymph node in the neck. They are stable over time, closer to 50% of those patients. And when we monitor those, 25% show an increase of size of lymph node in 6 months to a year. And when we have patient with thyroid cancer, metastatic disease to lymph node. So the question comes, are those the best candidate, or are we the patient who have stable disease? Again, as I mentioned, anxiety plays a role, and this is a decision where physician-patient relationship plays a major role about the best choice of treatment.
And my last question for you is just, what are your patients saying?
They're excited. They're super happy, especially when we see the volume dropping, when we see patients, when we say to them, that lymph node that had cancer is gone. It's exciting news. People are really excited when we get this outcome. They're excited even when the volume drops. They know something has happened. This tumor look significantly smaller. We see the outcome on the protein when we monitor their thyroglobulin. It dropped drastically in those patients. So they are excited. A lot of people feel better when they see a positive income instead of like, you have a lymph node in your neck. And the other thing is, a lot of people, when they get this result without any complication, they feel like, that's valid. This is good. I didn't have a problem with this. This was not hard. It didn't require me to go to the OR to have a surgery under anesthesia. It was under conscious sedation. So there are so many factors that make them really excited about this outcome and make them really happy.
especially the patients of ours, around 60% of them who've had a complete disappearance of the cancerous lesion. They're very happy and ecstatic. Obviously, we're keeping a close eye on them and keep repeating imaging and stuff. And we have a multidisciplinary team here of surgeons and head and neck cancer specialists and us. And so we all discuss these cases in the tumor board. And so far, the results have been phenomenal. And we're very happy to be able to offer this as an alternative method. We've also done similar cases for palliative purposes. So for example, in some situations, cancer can recur as a gross local recurrence, not in a lymph node. This is basically remaining cancer that a surgeon could not remove because it was so close to vital structure. And we were hoping that with radioactive iodine and other temporizing measures and other interventions, that these local remnant or recurrent tumor would not grow. But inevitably, in some cases, it does grow. And because it is already invasive of local structures, same situation has happened in the primary surgery still presents itself, that it is impossible to resect the disease, but we need to do something about it because if it continues to grow, it will cause problems. So we have been asked by our multidisciplinary tumor board to step in as a palliative measure in a few cases to shrink those things temporarily while we think of other treatment protocols, do genetic testing, think of new drug trials that can be applicable. And we've been able to offer that also for a few of our patients in a way to bridge and buy some time while we look at alternative therapies that work.
At the end of the day, treatment should improve quality of life, lead to a good outcome, and it needs to be kind of tailored. Every patient is different. Not everyone possibly respond the same way to same type of medical treatment. So medical care need to be personalized, need to be the right treatment for the right patient, and we need to have many tools to help people who have different medical condition, different situation where their treatment may differ, may not be the same.
I'm glad this is an option that you have available now. Thank you for telling us about that.
Thanks so much, Jennifer. Thanks.